you very much, CPD, and I hope I will do justice thing for everybody to learn, but also something for everybody to intervene. So let me start my presentation. So we chose a program about 3 presentations for this month. So I have modified the talk a bit to include risk factors for HPV infection, persistence, and of course, pre-malignant cervical cancer lesions. So normally this is a continuation of one thing. So you get infected, you get a precancerous lesion, and then of course you get cervical cancer. I will begin with a few frequently asked questions. So FAQs just means frequently asked question. People asked me, what is a gynecologist? Why are you a gynecologist? And so basically a gynecologist is a specialist doctor, obstetrician with knowledge to diagnose and treat cancers of the reproductive system. Those are about 5 cancers: cervix, ovary, endometrium, vulva, and vagina. And of course, we undergo specialized training, especially in surgery, radiation, and chemotherapy. We do perform also some surgeries on other reproductive organs because cancers spread. For example, cancer of the ovary may spread to the intestine. So as a gynecologist, you can do some cancer in those areas. It may spread to the bladder. So we have additional competences and skill in those areas. But also we provide consultation in terms of surgical assistance to other gynecologists in major complex surgeries. For example, placenta previa or creta per creta. And of course, we're supposed to be the consultants for laparoscopic surgeries that may go bad. Now, there is a major difference, as members should know, that people who have cancers will have different outcomes, both for surgery and oncological outcomes, if they are managed by gynaecologists compared to if they are managed by general gynecologists. So general gynecologists make a diagnosis and then refer to the gynaecologists. So a gynecology service basically just means that if a woman has a cancer, we are just part of a team which has a medical oncologist because they may require chemotherapy, pathologists to help us diagnose the tumors, radiotherapists, radiologists, or palliative care, and general surgeons sometimes because we will need them. So that's a gyne-oncology service, and that's where I work. So why are we dealing with this topic? Why are we again talking about cervical cancer? Number one, that January internationally is this Cervical Cancer Awareness Month. So in this month, all countries, nations in the world are focusing their talks on cervical cancer. But as part of the CPD, our members should be aware that WHO in 2020 developed a new strategy aimed towards eliminating cervical cancer. And this is the first strategy of its kind for elimination of a cancer in the world. So cervical cancer can be eliminated. And the state measurable goals that should be achieved by 2030, which is the 90-70-90 strategy. Of course, Uganda is lagging way behind in this strategy, but hopefully we can make some headway, just like we made some headway in maternal mortality. So what this means, they want 90% of the girls vaccinated fully, at least once by the age of 15 years for HPV. They want 70% of all women by the age of 35 have at least been screened once using a good test, high performance test, and again, at least by the age of 45. We have no screening program nationally, so this we cannot achieve as far as I'm concerned until we step up. Then 90% of those with cervical disease, not cervical cancer, cervical disease. So before you get a cancer, you get pre-malignant or the conditions which happen before cancer, receive appropriate treatment. And that's a factor of screening. So women who have positive lesions should be managed, and women who have invasive cancers should be managed, whether it is by surgery, radiotherapy, or chemotherapy. So that is the 90-70-90 strategy aimed at eliminating cervical cancer by 2030. Now, why are we focusing on cervical cancer? Yet the hot cake in reproductive health is maternal morbidity and mortality. And a lot of our effort has been, in fact, even including AOGU, has been around maternal mortality. Now, let me just give a brief background. If you look at the number of deaths, GlobalCan is that body that estimates cancer mortality and morbidity internationally. In Uganda, we estimate about 4,600 deaths from cervical cancer. That was in 2020, and this number has gone up. Now, if you look at maternal mortality reported in the annual health performance report of last year, these are deaths occurring in health facilities, just a comparison. If you look here, the number of women dying from childbirth last year was 1,276. So this is close to 4 times women dying from cervical cancer than that dying from maternal deaths. Yet we don't speak much about that. So in the previous 5 years, we have seen over 12,000 cases. These are the ones we know in the hospitals. But also, for anybody born in Uganda, what we call cumulative risk of cervical cancer. If you're born today as a newborn, for every 100 newborns today, female newborns today, by the time they are 74 years, 6 of them will have developed cervical cancer. So if you're born today, by the age of 74, 6 out of every 100 women will have gotten cervical cancer. So it's among the biggest burdens of disease and among the biggest killers compared to some of the things we are looking at here. So what is the cervical cancer to mortality incidence? So for every one new case of cervical cancer, or for every 100 cases of cervical cancer that we detect every year, 66 deaths will be reported. So 100 cases new, 66 cases of cervical cancer will die, meaning that this cancer is a very big killer in Uganda. So the other question is, what is a risk factor? People keep talking about risk factors, but what is a risk factor? A risk factor for any disease, but in this case, cervical cancer, is any condition you may have, any kind of behavior, or any other characteristic that is known to increase your chances as a woman of developing either the pre-malignant, those are the stages before cancer, or ultimately cervical cancer. Here I'll also include chances of acquiring HPV infection. So some of these risk factors may be modifiable. Modifiable means if you change something in your lifestyle, then that risk factor may either reduce or go away completely. Some are not modifiable. Now, cervical cancer risk factors, most of them are actually modifiable. So it means if you do something about them, there will definitely be a reduced risk of you getting that cervical cancer or HPV. Now, the risk factors for cervical cancer may be at the level of the individual, which are the majority. However, some of the risk factors are pushed or enhanced by the family, something lacking in the community, or as a result of the institutions that we serve. For example, hospitals, policies may actually affect the way we receive services that lead you to actually get cervical cancer. So what is the cause? The cause has been known for close to 40 years, and it is high risk. It is infection with high risk HPV, which we write as HR-HPV. And this is found in 99% of all cervical cancer samples on biopsy. Now, this high risk HPV has over 40 strains, but the most common are type 16 and 18 that cause more than 70% of the burden of cervical cancer, even in Uganda. And these are the types which are actually in the vaccines. So if you vaccinate all the girls that qualify, within a few years, you'll have reduced the burden of cervical cancer by 70%. The other subtypes will cause the 30%. Now, what is interesting is that because there are over 40 types, you may have several or multiple high-risk HPV, and there's evidence, local studies, that actually women with high-risk HPV, about 60% of them have more than one type of high-risk HPV. Hence, the need to screen. Now, of importance to members, if you get high-risk HPV, it will not give you cervical cancer. However, you cannot get cervical cancer unless you have high-risk HPV. That's what the statement means. HPV is necessary, but not sufficient. By itself will not cause cervical cancer. So there must be something else which actually reactivates the HPV for you to get the cancer. And those are called cofactors or another risk factor that must work together with the HPV to get cervical cancer. But if you have HPV alone without other risk factors, the likelihood of getting cervical cancer is almost zero. Now, HPV loves the skin and mucous membranes. So the mucous membranes in the mouth, the intestines, the genital areas, the skin around the genitals, the vagina and stuff like that. So it likes the skin and the mucosal areas. Let me skip this, but basically, let me talk about, people have always said HPV is sexually transmitted. So they have been focusing interventions only on sex, don't have sex, don't have sex. But HPV can be transmitted through non-sexual means. And there is evidence for this. So the key message here, we have vertical transmission of HPV, mother to child, just like you transmit HIV from mother to the child, hepatitis B from mother to child, syphilis, the same thing. So there is vertical transmission. And this has implications for policy in terms of screening pregnant women for HPV. And sometimes this, because of this vertical transmission, you may find newborns and adolescents have HPV even before they reach the age of vaccination. So we must vaccinate them early as a public health policy. Now, where is the evidence? So this study looked at a high-risk HPV in the oral and genital mucosa of infants during their first 3 years of life. And of course, the aim was to look at data for how do they acquire HPV? Does it persist or it is cleared in the oral mucosa? And what determines its persistence? So they had 324 infants at birth, and they took samples at 3 days after delivery, 1 month, all the way to 36 months after delivery. So what did they find? So they found HPV was present in 12-21% of the mouth samples taken and 4 to 15% of genital samples. So newborns can have HPV. So it means that during childbirth, if the mother has HPV in the cervix, there is likely going to be HPV in the newborn, either in the mouth or around the area of the genitalia. Now, persistence meant that about 1.5 of the infants remained HPV positive in the genitals at 26 months when the study was ended. Now, but also this second study done in China shows that there is actually vertical transmission from mothers to infants. Now, here they assessed the extent of HPV infection during childbirth period, the mode of delivery, and vertical transmission. So they assessed women, 209 women were assessed. And of these ones, HPV was found in 18.9% of the pregnant women, that is 55 of them, and 3.4% of the babies. So if you look at this, it's actually evidence that HPV is not only spread by sexually. Now, of the HPV positive women, if you look at their infants born to them, 18.2% or 20% of them had HPV. So there is evidence that HPV can be spread from mother to child. Let us look at people who say, I am a virgin, I have never had sex, I've never had penile intercourse, so I am safe. Still on non-sexual HPV. So the key message here, even in virgins, we have HPV, and there is evidence for that. If you've not had penetrative sex, you will still get high-risk HPV in your genitalia. Let's look at this. Many people come with genital warts and they have never had sex before, almost all male samples, and it was found in the fingers. It was found in the fingers of the finger brush samples of of some women and some men. So some people may not necessarily do penetrative sex with the penis, but they may use their fingers for sexual activity. So if they have been cleaning themselves and they have HPV on their genitalia, and they touch you in the genital area, they may actually transmit HPV to you. Or women who have HPV but have not been sexually active, as they are washing, they may actually pass on the HPV from the genitalia or the vulva into the vagina. And some cases have been reported among nuns in the UK over history. Now, we want to look at, they again looked at, okay, this is still the same thing among students. And they found that many of the students actually had HPV in their fingertips, but also some of their sexual behaviors was to do with the fingers. So members, please understand and talk to your client that it is unlikely to be very common, but people are changing their sexual behavior in a bid to prevent other STIs. So of importance, this study showed the high frequency of HPV in the vagina, not on the vulva, in the vagina, before first sexual intercourse among females. So these women were not sexually active in terms of penile sex, but they still had high-risk HPV. And so if you look at the numbers, overall risk, 16 of the 20-something of the 29 women actually had HPV, high-risk HPV. So even if you're a virgin, you will still have high-risk HPV, both male and female. That is the key message, that they are non-sexual transmission of HPV. So HIV and the and cervical cancer. So HIV causes immunosuppression, and HIV reactivates latent high-risk HPV, and this leads to causation of cervical cancer. So HIV is a group 1 carcinogen. This is according to WHO. So group 1 carcinogens are where there is clear evidence that if you have HIV, or if you have this factor, it is actually a cause of the cancer. So HIV is a known carcinogen for cervical cancer. And as such, cervical cancer has been called now an AIDS-defining illness. So if you have cervical cancer and HIV, we then put you in stage 4 because that's an AIDS-defining illness. So you have AIDS. So let us start from the journey of HIV. There are people who get HIV during the time of childbirth, pregnancy, childbirth, and shortly after childbirth, maybe in breastfeeding, perinatally affected children. Now, we have children who acquire the HIV, and we also have those who are born to positive parents, but never acquire HIV, what we call exposed children or exposed infants. So in this study, they assessed the prevalence of HPV in the mouth and the external genitalia of non-sexually active. So these were basically virgins, HIV positive children, and they compared them with HIV exposed but uninfected children. So what did they find? Of the girls, 23 girls who were positive for HIV, 30% of them had anogenital, had HPV, high-risk HPV around the anus and the genital area. And 17% of them, or 2 in 10 of them, had HPV in the mouth. So it means they acquired this HPV likely from the mother. Of those who were exposed, HIV exposed, but uninfected girls, 27 of them, you can see the risk was much lower, 7.4% versus 30.4% in the infected counterparts in terms of HPV around the anus and the genitalia. None of them had oral HPV. So it means babies who get HPV around the time of childbirth are likely to have high-risk HPV in bigger numbers than those who are not affected but exposed. So HIV, right from the time of birth, may cause problems. So we again now look at adolescents. We have left children born with HIV or those who are exposed. Now we look at adolescents, those who are HIV infected and those who are HIV non-infected. Now, why I'm putting a lot of effort here is to show members that the problem starts very early of the journey to get cervical cancer. And we must vaccinate these girls as soon as possible. In my opinion, from 8 years, vaccinate them. Now, adolescents, HIV infected and HIV uninfected adolescents. Now, these people, they looked at a cohort of adolescents between the age of 13 and 18. And what did they find? So they found HPV was prevalent in 334 girls. And people who had HIV, the girls who had HIV, took a long time to clear the HPV. So HPV was more persistent in the girls who were HIV positive compared to the girls who were HIV negative. So for those who were HIV negative, they cleared the HPV within about a year, 403 days. For those who were HIV positive and adolescents, their clearance took almost 3 years. So they had a longer time to clearing the HPV. And cervical cancer tends to happen in people who have a persistent persistent HPV infection. So HIV increases persistence, hence will predispose these adolescent girls to cervical cancer. So we must vaccinate them as early as possible on HIV programs. Now, persistence with HIV has been shown right from childbirth into adolescence. What about in adult women? How do they clear the HPV? So once they get HPV, now these ones may not necessarily have HIV, but once they get HPV, we still compare HIV status. Now for the new incident means new HPV infections. They took longer to clear in women who had HIV compared to those who were HIV negative. So all these studies are showing you that HIV reduces clearance or increases persistence of HPV, of new HPV infection. So HIV programs like the government has done now must include both HPV vaccination and screening as a must for all those women. Now, sexual behavior. Of course, people talk about multiple sexual behavior, sexual partners. Some people may say, me, I have only one partner, but they have what they call serial monogamy. They keep changing partners one at a time, but they keep changing them. So the key message here is that sexual behavior will influence your risk of getting HPV infection. But also, if you have a risky sexual behavior, HPV tends to persist because you tend to have a lot of or recurrent or new infections of HPV, and thereby it becomes a problem to clear them. So that is how you will likely end up with cervical cancer because of the increased risk of HPV infection, persistence, and clearance. Now, this was in adolescent girls in Nigeria. And what did they find? In this study, their mean age was 14 years. 15 years, 14.9 years. Now in Uganda, if you compare, 15 years is where most of the girls start having sex in Uganda. So they found of the girls they assessed, 13% of them had HPV in their vaginal swabs. And the earliest detected vaginal infection was between 10 and 12 years, respectively. So, and most of them, the peak age for high-risk HPV was between 16 and 17 years. So if you look at Uganda's setting, at the age of 15, they're already having sex. So the peak of HPV infection is about 16 to 17 years, which may be similar to Uganda. So the prevalence of girls in this cohort was quite high, and a lot of them had HPV before the age of 9. So we should start. So this has also an implication for screening. So sexual behavior. Now, in this study, what I don't show here is that some of them between the age of 9 and 12, those who had HPV, most of them had forced sexual, sexual abuse of some sort. So we need to look out for girls who come to the hospital with the discharges around this age because there may be issues about sexual abuse. Now, the role of sexual behavior again. Now, but this was in young women. Now, for the young women, what is important is that because of their sexual behavior, they tend to have repeated HPV infections. So they may keep either changing behavior, they may have STIs, and therefore, many of them tend to have another HPV, it clears, another one comes because of the way they behave. So sexual behavior, multiple sexual partners, and the behavior of the male partner may actually play a role in some of these things to do with HPV. Now, when I'm talking about HPV, HPV is the cause of cervical cancer. So by default, HPV cervical cancer is just one continuation. Now, in this prospective study, they looked at women who had not been screened before to look at incidence and clearance. Incidence means new cases. So here they looked at 2,065 women between the age of 18 and 29 who had not been screened before, but were followed up for 12 months and asked to provide a cervical sample every 3 months. And of course, what they found was they also had very high incidences of HPV, or close to 69%. And the clearances also were, much as the clearance was good, the rates of HPV were very, very high. So in that age group, sex, once they begin having sex and you screen them, you will find lots of HPV. Now, let us first pause a moment. Let us pause a moment. We have this elephant in the room called combined oral contraceptives, COCs. Now, please do not refuse to prescribe COCs for women who come for family planning services. Do not stop. If you're putting somebody on COCs and they are more than 5 years use, please make sure that they screen them for cervical cancer. So each time you're going to give family planning, screen the woman for cervical cancer. Don't refuse to give them because COCs have other benefits. However, that said, COCs have been classified by the WHO monograph of 2019 as a group 1 carcinogen. COCs potentially cause cervical cancer or potentially lead or predispose one to cervical cancer, just like the HIV. However, WHO still recommends the use of COCs together with cervical cancer screening, as much as it's a group 1 carcinogen. So don't go saying, oh, it will cause cancer. No. For women who are using COCs, screen them. Now, in this area, I'll explain why COCs and things like parity will predispose somebody to cervical cancer. So that is the paper by Cogliano that was published in the Lancet 2005. And as I've told you, it is listed. It is carcinogenic alongside HIV and tobacco. But the risk is there if you take COCs for more than 5 years. If you stop them, the risk reduces quickly. However, the combined contraceptives also have other benefits, like they can prevent endometrial cancers and they can prevent ovarian cancers. So if you use them for more than 5 years and you're getting screened for cervical cancer, your risk for endometrial cancer and ovarian cancer will also reduce. So advise long-term COC users to do regular cervical cancer screening. So women who are coming for oral contraceptives are likely coming to you as a health worker. So don't tell them they should not use the COCs, just advise them to screen. So this is the monograph, the IRS, International Association for Research in Cancer monograph, and it lists the cancer site, carcinogenic agents with sufficient evidence in humans. So there's evidence that COCs, the combined COCs, HIV, HPV, and tobacco smoking are known to actually be carcinogenic agents. Now let us look at parity. That said, COC use in Uganda is still very low. I think it should go up, but it is still very low. Now, let us look at parity. Parity means deliveries. When talking about parity, we're not talking about abortions. You're looking at women who have carried a pregnancy to at least 7 months and had a delivery, which we call, that is now parity, para 1 or something. If you abort, we don't count you in this category because your risk factors are there. But parity and age at the first term pregnancy, term means you've reached 9 months. And how do they affect the cancer risk? So the key message here for members, as a risk factor, the higher the number of deliveries at term, the more pregnancies you carry to 9 months, the higher your risk of cervical cancer, and I will explain. And the earlier you begin sex, the age of the first term pregnancy. So if you have pregnancy below the age of 15 and that, your risk is different from somebody who has the first pregnancy, say at the age of 30. So the earlier the age of first pregnancy or first term pregnancy, the higher the risk of cervical cancer. Now in Uganda, we know that 70% of our girls below the age of 19, by the age of 19, are either married or have had a child. So age at first term pregnancy is a problem in Uganda, and that may explain. So in this study, or in this review that that used the number of women in assessment, these were the results. And I will explain this. Let us look at only this section of the chart, which is easier to explain compared to this one. So if you're 16, this is age at first pregnancy, age at first pregnancy in terms of years. So, and you're nulliparous, first pregnancy. If you're 16, your risk of getting cervical cancer is 3 times higher than that of somebody who is maybe at a much higher age. So the risk as you grow older reduces. So women who are who get their first pregnancy at the age of 30 have a lower risk of cervical cancer compared to those who get it much earlier. So if you're 16 all the way, you'll see that your risk is reducing for the first pregnancy. So at 29, if you conceive, your risk is much less than somebody at 16. If you're 30 and first pregnancy, your risk is lower than somebody at the age of 20. So early pregnancies or early age of childbirth is a problem. Let us look at this one also. Just a moment. So still the age of first pregnancy in terms of parity. So for women who had their first pregnancy at the age of 25 or more, you will see their risk, if it is between 1 and 2 pregnancies, their risk is lower. However, the risk keeps increasing with the number of pregnancies. So if you have 5 or 6 pregnancies, your risk is much higher. If you have 7 or more pregnancies, your risk becomes higher. The same thing with all the other age groups at the age of first pregnancy. However, what you notice is at 7+ pregnancies or at all number of pregnancies, the risk is much higher if you conceived your first pregnancy at a much earlier age. So early pregnancies, early marriages, early onset of sex will give you a much higher risk compared to later onset of sex, of pregnancy for each of these women. Let me skip this and I'll talk about the STIs. So which STIs have been known to cause or to promote cervical cancer? Which STIs put you at risk? Unfortunately, in Uganda, we screen for syphilis, HIV, but we don't have screening tests yet at a public health facility level for things like chlamydia. Now, chlamydia is a fairly common STI if you look at lower studies. And the key message here for people who have chlamydia, it normally comes with infertility and other things. However, chlamydia, because it is painless, it will not show any symptoms, but it may come with issues to do with cervical cancer or infertility with damaged fallopian tubes. Now, chlamydia is implicated in altering or disrupting the DNA damage response. So when cells become abnormal and they're trying to repair their DNA, chlamydia will disrupt that process. But also chlamydia interrupts or alters the immunity in the cells. So chlamydia basically causes immunosuppression. So women who have multiple sexual partners, early onset of sex in terms of years, women who do not screen are likely to have chlamydia and they will likely get cervical cancer because of the altered immunity. So what I was saying is basically this, that chlamydia, if you have chlamydia, it will disrupt your DNA damage repair systems. And this will eventually cause cervical cancer or promote cervical cancer. Some people believe that chlamydia by itself can cause cervical cancer. However, that is yet to be proved because of the few cases where you'll find chlamydia alone. Most times you'll find chlamydia with HPV. So chlamydia among the STIs is a big problem. Syphilis, not a very big problem. So HIV, problem. Chlamydia, a problem. Hepatitis viruses may be a problem. So for the people who want to read more science, these are the pathways, but let us focus now on tobacco. Fortunately, in practice, it is very difficult to find women who smoke, though the number is increasing because of urbanization and changes of lifestyle. So tobacco smoking and cervical cancer. Tobacco is also known to actually predispose people to cervical cancer by altering the immunity in the cells and also causing the HPV to persist in the cervical cancer cells. So tobacco or the nicotine will go into your cervical cells and alter their immunity, and hence, if you have HPV, it will tend to cause problems. So those are individual risk factors: tobacco smoking, STIs like chlamydia, HIV, high-risk HPV, parity, high parity, and I know Busoga, our fertility rate is still high, about 5.2, according to the latest estimates in the UDHS. High parity, we have high rates of teenage pregnancy, so those girls are likely to get cervical cancer in the future. And of course, infection with high-risk HPV. So if they have HPV, they will also bear children with HPV to some extent. But of interest in Uganda is that we have factors beyond the woman, which we call factors to do with external factors. Now, Kampala is a good case study that shows you that factors in the institutions may actually predispose the women to actually getting cervical cancer. Now, in Kampala, there is a study which was published a few years ago that took data from between 2008 and 2015 from the Kampala Cancer Registry. And they looked at the map of where the cancers were coming from within Kampala. So this map, these maps, we're looking at Kampala. Incidence means new cases of cervical cancer in Kampala. Now, what is unique about Kampala? Kampala, I'll talk about that later. But basically, in the registry, they had 100 records. And of those records, 90% of them had a valid sub-county, and about 90% of them had a valid parish name. So they could actually tell where the women actually came from in Kampala. Just Kampala alone, not the rest of the country, Kampala alone. So they tried to map out the areas of like cervical cancer incidence in the region. And they found that there was significant variation within the sub-counties, highlighting the importance of actually taking this data in the fight against cervical cancer or other disorders that we may look at. So this is the map of Kampala and the sub-counties. So there is Kawempe, Central, Rubaga, Naweru, Nakawa, Chira. This is now metropolitan areas. Machindye, Savagabo, Machindye. Now, the incidence here, the incidence red means that these are areas which have very high density of women with cervical cancer. And this will happen to be Kawempe and central parts of Kampala, central divisions. Now, the next incidence was in Machindye, and then followed by Nakawa. If you look at the incidence, like in Chira, it was much less than that in the areas around Kampala, or what we actually know as Kampala. So this area of Kampala, the 5 divisions of Kampala, actually have very high incidences. But Kawempe and Central, if you look at the map there, the red areas there, they show you that there is a big problem in those areas. Kawempe, Central, Machindye, Nakawa. Now, these areas follow the highways. So if you follow the highways in Kawempe, Northern Bypass, Ginger Road, those are the areas. If you also follow the slummy areas, the slums, these high incidences tended to be around the areas of the slum. Now, why is this important in terms of factors of institution? Now, Kawempe and Kampala basically has the highest number of referral hospitals, concentration of referral hospitals, and it has the cancer, it has UCI, it has Kawempe National Referral Hospital, it has Women's Hospital, it has in Zambia, in Machindye, it has Rubaga, Mengo and Rubaga hospitals. So the highest concentration of hospitals is in Kawempe division. But the risk of cervical cancer or the incidence is highest in Kawempe and Central. It means there is something preventing women from crossing the road from Katanga to go to UCI for screening. So either because of a lack of a national policy or because of a lack of awareness, either from the health workers in those areas or from the communities. So without policy, without awareness programs, without policing the women to go and get screened, even when you have the experts in those 2 areas here, or in these 5 areas, divisions, women still get cervical cancer. So having hospitals will not improve the situation, but maybe awareness, maybe moving to the communities to screen the women may reduce the incidence of those cancers. And I'm sure this situation, if it is mapped in places like Mayuge, where I know they screen ginger, there may be a similar story. So let us think about the risk factors, not only from the client's perspective or the client's individual risk factors, but also risk factors from the institutions where we serve as gynecologists, doctors, midwives, and the rest. So let's take a breath. I have tried to explain some of the risk factors, and I hope people have picked that all the way from pregnancy, childbirth, adolescence, young women, all the way to wherever you will end, you have a risk of getting HPV, whether you have had sex before or you have not had sex before. So don't say, my girl is a virgin, she didn't have HPV. You may get cancer, my friend. So I'm spreading awareness about the risk factors, and I would like to end my presentation here. I'll just ask to speak about risk factors. What next? Over to you, BHF. Dr. Mukembo, over to you.
Yes, Dr. Mukembo. Yes, Dr.
Yes, thank you very much, Dr. Musana. Sorry, I was muted, so I wasn't able to communicate. Thank you very much, Senior Dr. Musana, for that very elaborate and very wonderful presentation that you have done justice to the members of Busoga Health Forum. On my side, I thought I was just starting the session. Unfortunately, on your side, you were you were winding up. Wow, it was very educative, with a lot of things to digest and with a lot of interesting findings. I wish we can have more discussions of this nature, and I'll be grateful. Maybe next Friday again to have this sharing of this magnitude. And I wish to also re-emphasize that the females in the house, we have read and we have seen, we've heard. Now, sometimes when we talk in class or when you hear on radios, you may think it is just a normal usual doctor talk. But Dr. Musana has added some more flesh and spices to what you usually hear by giving you research findings and publications. Most of us, we are allergic to reading, especially junior doctors. We don't want to read to know what has been published. But you added that extra spice to the audience to know that what you are speaking has been thoroughly researched and is out there, and members can access it and read to get details. And that additional information is very important for us who deal with the young people. On my side, I work with the university, and you can understand much of my population that I handle on a daily basis are these are largely young people in the age bracket of 18 to 30 years. Majority of them are between 18 to 25, very sexually active. And indeed, a topic of this nature, talking about cervical cancer, risk factors as elaborated is very, very important. I want to encourage health workers to always encourage female patients who come to them to consider screening for cervical cancer. especially on the risk factor you noted about STIs. We commonly treat them, and you see even a qualified doctor. The person is talking of abnormal vaginal discharge, and the first request is urinalysis. The woman is not presenting urinary symptom, and we have forgotten to do basic HVS and basic screening tests as you have elaborated. I want to thank you very much, Dr. Musana, for that very wonderful, elaborate presentation. Perhaps I would also ask, the red zones, as you noted out in Kawempe and Kampala Central, could they also be presumptive, or that because the areas in that, because the facilities which do much screening, or because even the highly educated people who have access to this information are within those same areas? Because like you noted, the major facilities are within Kawempe and the Central Division. And then also the high incidences within the same divisions. Could it be related to the advances in technology or access to information that we have? Also, those who are screening most to be coming from those regions, hence the high incidence. Could it be related to transactional sexual activities? I was even here thinking louder. Kawempe division also harbors the Muslim world. There are so many Muslim community in Kawempe and the Kampala Central. Could it be that the many wives that most of them have, could it be a risk factor to this cervical cancer? I'm just speaking aloud. Someone should not stone me for talking about religion. Thank you very much. I want to open the floor for questions and answers. Those who are registering for CPD points, a link will be shared, and you'll be able to check the chat and you register for the CPD points. I want to begin by getting a submission from one of our life members at Busoga Health Forum. Dr. Pontian Chiwanuka, kindly unmute and submit.
Thank you so much, the moderator. Thank you so much, Dr. Musana. This is Dr. Pontian, Uganda Hospital. One of the questions I wanted to ask Dr. Musana is about the parity, that the higher the parity, and especially if the first pregnancy was in the teens, like 15, 16, the higher the incidence of the prevalence of cervical cancer. Yes, you have explained to us about the chlamydia and also HPV, HIV, but then what science lies behind parity? Does it disturb the cervix? Does it, during the healing that disturbs the DNA? What lies there? And then I know it is not today's discussion, but this week I've had 2 women with the cervical, with the discharges, and then they had cervical lesions, which were really pointing to cancer. But all of them refused to do to take off the biopsy. I don't know what community intervention we have as BHF or Dr. Musana can suggest to address this issue, because it's a big problem. They come in late stages. They don't want to be taken off the biopsy, and so on. Thank you so much.
Yes, thank you very much, Dr. Pontian, for that wonderful inquisition. Can I have Dr. Shamim Nantege, Beira, Uganda, Hoima region? I understand you are the reproductive health coordinator in Beira, in Hoima region. Kindly submit. Shamim? Shamim, are you able to submit? Dr. Shamim.
Thank you. Dr.
Have we lost Dr. Shamim? Oh, sorry. When she comes back, she will submit. Dr. Musana, would you like to quickly respond to Dr. Pontian?
Yes, of course, my colleague, Dr. Pontian, is a gynecologist, and I know there are many gynecologists on this forum. There is something I skipped because it would take a lot of time. This one. So basically, the cervix has two kinds of cells. They are what they call the squamous columnar, so the squamous cells, which are half like the skin. And then there's also the columnar inside the canal of the cervix. Now, the columnar ones are the ones which produce the cervical mucus. Now, oral contraceptives, let me first give natural course history because I try to give a bit of history on this for members who may not be medical. Maybe you will not understand. So at childbirth, during my pointer is still bothering me. Sorry, just a second. So prior to puberty or at birth in the neonate, remember that during pregnancy, the placenta is secreting very large volumes of, very large amounts of estrogen. Now, estrogen is a growth hormone and has an effect on your cervix. So your cervix grows bigger and bigger during the time of pregnancy. And as it grows bigger, it will expose these cells, the columnar cells, to the vagina as it grows bigger. So the gynecologists may know what they call the squamocolumnar junction or something called an ectropion. So if you're pregnant, each pregnancy is increasing your levels of estrogen to very high amounts. So you're exposing more of this columnar epithelium to the acidic environment of the vagina. Now, because those cells are not meant to be in an acidic environment, once they're exposed, they have to transform to become columnar. They have to transform to become another type of cell. So during this transformation that is happening because of the large amounts of estrogen causing cervical enlargement, you're exposed more to HPV, the cells are vulnerable, and you're exposed more to the vaginal acidity, so they begin transforming. And over time, if you have repeated pregnancies, factor in the fact that even during pregnancies, you still get STIs. During pregnancies, you'll also get more transformation happening. And during pregnancy, you're still having sex. So that repeated trauma and childbirth in an already traumatized cellular group will predispose you to cervical cancer. So the more pregnancies you have, the more damage you have to that area of the cervix, which is columnar. And by parity, you will get a problem. Now, estrogen in pregnancy is the cause of the increase in size of the cervix and increase in the size of the exposure of these columnar cells. Now, the same messages for the COCs. COCs contain estrogen in much smaller amounts, but using them for over 5 years, it is almost the same thing as being pregnant. You're making the cervix grow bigger.
Hello.
You're making the cervix grow bigger and you're exposing more columnar epithelium to the acid in the vagina. And those cells have to transform over time. So they're transforming almost every day for 5 years. So the amount of mistakes you will have in transformation may predispose you to cervical cancer. So estrogen and COCs, estrogen and parity are how you